Thank you, chairpersons, and I would like to thank Dr. Kumaravel sir, Dr. Aruna madam, Dr. Raghuram, the entire team Receptor 2026 for making me a part of yet another Receptor, and it's always nice to be back home. So electrolyte disasters, as rightly pointed out, I think in endocrinology, electrolyte disorders are often underestimated, and until it becomes an ICU emergency where these endocrine disorders actually become endocrine or electrolyte disasters. So how do we really fix them? Now, the most important thing that we need to remember is that a simple fact that these electrolyte disorders, when you look at the reports, don't just reflect the numbers on the report, but actually reflect the underlying water balance, neuroendocrine control, and more importantly, the therapeutic errors that would have happened in the subsequent past. So with this background in mind, we will look at what are the electrolyte disorders, how do we really fix them, and more importantly, how do we actually prevent them. Now, in endocrinology, the electrolyte disasters are often associated with acute hormonal deficiency. By saying so, I mean cortisol deficiency, thyroxine deficiency, all these things can present with electrolyte disasters. But also, unmonitored rapid correction of any chronic condition can also cause a disaster more than the actual intent to correct it. Now, whenever we talk about electrolytes, we often consider these three critical ones: sodium, potassium, and calcium. Now, out of this, sodium becomes the hero because most of the times, not just by presenting as a disaster, treating sodium can actually make the problem being a disaster, and that is why we are going to focus on the sodium. I'm going to talk about the hypernatremia. Now, hypernatremia is defined when the sodium is more than 145 milliequivalents per liter. Now, when I say this 145, this number doesn't mean just the total sodium content, but it just reflects that there is a subsequent or a coexisting significant water deficit. So this 145 reflects not just sodium, but also the underlying water balance. Now, the most important thing that we also have to remember is whenever you encounter a value more than 145, it goes without saying that that patient is also having hyperosmolarity and also hypertonicity. I will tell you why in the subsequent slides. Now, the most important thing we also think about is an entity called a pseudo-hypernatremia, where low protein, low lipids can also cause a slightly highish sodium, may not actually have a high sodium, but this is very rare when compared to the pseudo-hyponatremia. So generally, we don't consider it much, but we need to keep that in mind as well. Now, why do I say this is a disaster? It's for the simple reason that the hypernatremia per se, the higher the sodium, the more rapid is going to be the onset, and more importantly, catastrophic correction errors can result in a significant neurological worse outcome, and that can also cause a high mortality. And that is why we call it as a disaster. Now, I would like to tell you about a love story. Now, this is useful to remember how the sodium and water are balanced in the fluid compartment. Now, in our body, the fluid compartment is a very fixed volume. You can't add much, you can't take away much. So you have the extracellular compartment, as you can see here, and you also have the intracellular compartment. Now, the most important thing we need to remember is the sodium never crosses cell membranes, whereas the water freely moves across the cell membranes, across the compartments. So sodium is imagined as a wife, maybe a newly married husband and wife, and the husband is the water. So wherever the sodium goes, the water just follows. So there is no rule other way. It's only the sodium that leads the way and the water just follows. So what happens in hyponatremia? The sodium gets trapped inside the cell, so the water moves into the cell, causing the cellular bulge or cellular expansion. Whereas in the hypernatremia, it's the other way around. The sodium stays outside the cell, so the water also leaves the cell, gets into the extracellular compartment, causing cell shrinkage and neuronal damage. Now, this is important to know because hypernatremia per se causes cellular dehydration. By having a lot of errors that can go while we manage patients with hypernatremia can worsen this, and that is the reason why we make it as a disaster. So let's understand this clinical case, which would help us to understand how we need to manage hypernatremia and how can we prevent and fix the disasters as early as possible. This is a 20-year-old lady who came to us with headache, bilateral lower limb weakness, altered sensorium, and polyuria for the last 3 months. She was admitted elsewhere, and she was diagnosed to have cortical venous thrombosis. Now, in the background history, she was actually operated for a supracellular germinoma at the age of 8, and she underwent subtotal excision, following which she was given radiotherapy and chemotherapy, and she had developed panhypopituitarism, and for which she was on hormone replacement therapy. So her first lab clearly showed that the sodium was very high, the sodium being 152. Rest all the electrolytes were normal. So what went wrong in this young lady? Now, the moment the sodium was seen as 152, the healthcare provider jumped in, was super enthusiastic. So he started this lady on half normal saline, which is 0.45% saline, and also 5% dextrose together, along with vasopressin. So he is trying to treat this hypernatremia by giving fluids and by restricting the excretion by adding on a vasopressin. So this is definitely a rapid correction. So what followed this? Patient developed a seizure. So the moment the patient developed a seizure, again electrolytes were repeated, and the sodium had actually dropped by 20 milliequivalents, hitting a low of 132. Now this 132 absolute value may not really create an impact, but all we need to remember is there has been a 20 milliequivalents drop within a span of 8 to 12 hours, which is quite significant. So immediately what this physician did, he started on 3% saline because he wanted to correct this mild hyponatremia of sodium 132. So he gave 3% saline, and immediately patient had recurrent seizures. There was a drop in sensorium, and the patient became comatose. So he rechecks the electrolytes. Sodium became 158, and it's again up by 26 milliequivalents within the next 12 hours. So all this ups and downs of sodium happened in the first 24 hours of the hospital admission, and then this patient got referred to us because of worsening sensorium. So on arrival in the ER, she was very drowsy, not arousable. There were evidence of severe dehydration. She was already on ventilator, so we could not assess the thirst in her. She had tachycardia, lowish blood pressure, and neurologically clearly pointing towards a depressed sensorium and a coexistent cortical venous thrombosis. So when do we have to think about hypernatremia? Now, whenever you have patients who have some cognitive dysfunction, some neurological dysfunction, plus signs of dehydration, there could be volume depletion. So when you have this combo, you always can take it that would be definitely some element of hypernatremia. Now, this patient had cognitive dysfunction, as you can see, and also signs of volume depletion like tachycardia, a mild hypotension, and a significant peripheral dryness of oral mucosa, and so on. Now, rarely, hypernatremia can be presenting in an outpatient setup where patient complains of very non-specific symptoms like weight loss, some tiredness, some fatigue. That is also possible, but most often it is a very mild hypernatremia, or more often a chronic hypernatremia. Now, these are the labs when this lady came in. Sodium of 163, potassium chloride bicarbonate normal, clearly pointing towards a central etiology and isolated sodium problem, not the usual AKI and the renal loss that we encounter. Now, looking at the osmolarity, you can see a hyperosmolar sample, urine osmolarity being low, and urine sodium 24. So we did the pituitary panel. The free T4 was normal. We didn't do a cortisol because patient was already on IV hydrocortisone. FSH, LH low, and prolactin again low normal, clearly pointing and favoring the hypopituitarism that this lady already has. So after diagnosing or identifying hypernatremia, what do we really have to keep in mind before we jump on the fluids and the vasopressin or desmopressin? Now, there are two things which we need to keep in mind. One is you're trying to find out what kind of hypernatremia this is, what we are dealing with. Now, the first thing is look at the sodium. So you categorize the patient as having either mild, moderate, or severe hypernatremia. So when the sodium is between 146 to 150, you take it as mild, 151 to 155, you take it as moderate, and anything more than 155, we take it as severe hypernatremia. The second factor we need to keep is the time of onset. So if the onset of symptoms are less than 48 hours, you take it as acute hypernatremia. If the onset of symptoms are more than 48 hours, it is taken as chronic hypernatremia. The third component is volume status, which is the most important thing that we need to keep in mind and look for before we start treating this patient. So categorized as hypovolemic, euvolemic, or hypervolemic. So with this three components, if you put the components for our patient had a severe, an acute on chronic, and a hypovolemic hypernatremia, which is very symptomatic. Now, before we start the fluids, the second thing that we need to keep in mind is what exactly is the pathological abnormality that is contributing to hypernatremia in this given individual. Now, hypernatremia occurs as a consequence of water loss or a sodium excess or even both. Now, this is important to know because if it's going to be only water loss, our management is going to be different. If it's going to be a combined water loss and sodium excess, the management is going to be different. And if it's going to be only a mild sodium excess, again, the management is going to be completely different. Now, whenever you have patients with this, the volume status is going to give you an additional clue what you really need to do for this patient. Now, if you have an euvolemic patient with hypernatremia, most of the times it is only a pure water loss or a water deficit, and many times we will be able to manage just with water replacement. Now, the conventional diabetes insipidus, where there's a problem in the pituitary, often comes as a euvolemic hypernatremia, and therefore management of DI becomes much more easier and much more straightforward. But when you have patients with hypovolemia, where you have a combined water loss and some sodium loss, that's going to be tricky because here you need to actually manage both fluid as well as the sodium. Now, this hypovolemia happens when there's a pathology above the pituitary, especially when there's a hypothalamic involvement. The last category is hypervolemic category, which is most often associated with very mild hypernatremia, and it's very commonly seen in our endocrinological problems like primary hyperaldosteronism, Cushing's syndrome, mineralocorticoid excess, and so on. So this has to be kept in mind because once you determine the volume status of the patient, that's going to help us to intervene in this patient. Now, what are the hormones that regulate or contribute to sodium homeostasis? There's a huge list of components you can see from renin to angiotensin to aldosterone, ANP and BNP, but the most critical regulator of sodium homeostasis is vasopressin. Now, this vasopressin comes from the posterior pituitary, but acts at the level of the renal tubules. Now, this gets triggered whenever there is a reduction in the blood volume, reduction in the blood pressure, and more importantly, whenever there's a drop in plasma osmolality. So this gets secreted from the pituitary, gets into the renal tubules, reabsorbs sodium and water in order to maintain the blood volume. Now, what really happens whenever there is an increased plasma osmolality, or when you have a volume depletion, when you have a solute excess in the plasma, what really happens? Now, whenever there is an increase in plasma osmolality, these osmoreceptors in the circumventricular organs like the subfornical organ, the organum vasculosum of lamina terminalis, all these areas get triggered. Now, once this osmoreceptors get triggered, there are two responses. One, it goes and stimulates the preoptic nucleus in the hypothalamus and increases the thirst so that patients can take in water and they are able to satisfy the water deficit or self-correcting water deficit. The second action is it also triggers the paraventricular nucleus and supraoptic nucleus in the hypothalamus, causes more vasopressin release. So vasopressin goes and blocks the urinary loss of water, reabsorbs water in the kidney, and therefore maintains the plasma volume. So one is to stimulate thirst, two is to prevent the renal loss of water so that the total body water is maintained. Now, this is how the vasopressin acts. The vasopressin acts at the level of V2 receptors in the collecting duct, and you can see it opens up the aquaporin channel, gets in the water from the renal tubules, and also gets in the sodium. Now, this is important to know because both these two steps, stimulation of thirst and prevention of renal loss, has to be in place for somebody to auto-correct the water deficit. So, thirst is the most strong protection that God has created so that we don't get dehydrated, we don't go in for an acute renal shutdown. So whenever there's a drop in blood volume, as I already told you, the thirst gets stimulated, somebody drinks water, the volume is restored, the water deficit is taken care of. Now the problem comes in patients like our patient, where there is a hypothalamic dysfunction. This particular median preoptic nucleus gets damaged, and that is the reason why they lose the ability to have thirst. So they are not thirsty even though they have severe dehydration. So this has to be kept in mind. So this patient has absolutely no vasopressin and also doesn't have the protection factor, which is thirst, and therefore there is no natural defense to help this patient autocorrect the water deficit that she has actually had. Now, how do we have to interpret an acute and chronic hypernatremia? So whenever there is hypernatremia, there is hypertonicity, and therefore there is a damage to the neuronal cells, and the risk of osmotic demyelination, seizure, all that comes in, especially when it's an acute hypernatremia. Now what happens to the chronic hypernatremia? When somebody has a high sodium for a longer period of time, which means more than 48 hours, the other solutes come into play, because I told you that sodium gets in the extravascular compartment and extracellular compartment, and water also gets into the extravascular compartment. Now inside the cell there are other osmolytes which get trapped. For example, some beautiful looking girls come into this cell, so automatically the water thinks to leave the wife in the extracellular compartment, moves back into the intracellular compartment, and that causes the cellular expansion, and therefore it's trying to recover. So the brain volume gets restored, and this is a very protective cerebral adaptation that happens in chronic hypernatremia. So in chronic hypernatremia, we need to be very, very slow and careful in the correction. So coming back to a patient, this patient has hypernatremia. She has adipsia, and she also has diabetes insipidus. So that helps us to make a diagnosis of adipsic diabetes insipidus in this particular girl. So when you look at hypernatremia per se, I told you the first thing that you need to do is volume status. So you classify based on hypovolemia, euvolemia, and hypervolemia, and most of the times the isolated DI comes in euvolemia. When you have hypovolemia with absence of thirst, you consider these kind of patients with hypothalamic dysfunction. So how do you treat? Whenever there is water deficit, give fluids. Whenever there is going to be a euvolemia, just give desmopressin to correct the DI. That would take care of it. So deciding on whether it's water or desmopressin or both is dependent on the etiology of hypernatremia. So what do we do for this patient? Now the first thing we need to do is calculate the free water deficit. Now this free water deficit is calculated by this formula, total body water into the actual sodium minus desired sodium divided by the desired sodium. So when we calculated, the water deficit that this lady had was 1.25 liters. Step number 2 is to also compensate for whatever losses that had occurred. So especially the urine output, when patient is on ventilator, the insensible water loss, all these things also should be added. So water deficit of 1.25 liters, urine output of 4.4 liters. So the fluid that has to be given back to the patient is 5.65 liters. So that has to be planned over a period of 24 hours, which comes to about 235 ml per hour. Step number 3 is, how do we replace this 235 ml per hour? It is always better to replace it through the enteral route or through the oral route, because it's easier for the fluid to get accustomed rather than giving bulk amounts of IV fluids. So we decided to give 100 ml per hour as half normal saline and 135 ml per hour as free water through the RT. Now the repeat sodium after 12 hours was 157 milliequivalents, and this is not a surprise because often we overshoot, and that is the reason we need to be very slow in reducing the sodium. So whenever in chronic hyponatremia, we often target 4 to 6 milliequivalents reduction in 24 hours, whereas in acute hypernatremia, you can even go up to 8 to 10 milliequivalents per liter reduction. So this was a serial monitoring. You can see that the sodium was gradually stabilized, and we would be happy to keep it in the high normal or slightly high, because these patients have a very adaptive mechanism. They don't even tolerate a sodium of 135 to 140, but they tolerate mild hypernatremia really, really well. So at discharge, this patient sensorium improved. There were no further seizures. We were able to fix and maintain the sodium about 144 to 148. The most important key factor in this patient was to fix the fluid intake. So depending on the output, we fixed the fluid intake, and that really took off the pressure from us as to calculate fluid every 8 hours or every 12 hours. We had to give desmopressin, and this patient was doing well with half and 1 of 0.1 milligrams of desmopressin. We continued high zone and thyroxine, which are the pituitary hormone supplements. We had to stop oral contraceptive pills in view of the cortical venous thrombosis because we were not sure if the CVT was just because of hypernatremia or because of OCP. So we did stop that oral contraceptive pills. So how do we avert these disasters? So the first disaster was a rapid overcorrection. So how do we correct it? The first step is to avoid rapid correction, especially in chronic hypernatremia. When you're not able to understand the onset, always presume that it is chronic hypernatremia and go slow. You will never be wrong. The second important disaster was a wrong fluid choice, combining half normal saline, 5% dextrose, and desmopressin. So always go with fluids first. Look at the sodium, understand how the patient is responding, and then add on the desmopressin as and when required. The third important component was giving IV fluids and desmopressin as a combo. As I already mentioned, giving free water in the oral form through the enteral route is always safe. You allow the body to get accustomed to the extra fluid that it is receiving rather than just pushing in large amounts of IV fluids. Fourth and most important thing, I think it was already emphasized in the previous 2 lectures, clinical monitoring is the key. You need to monitor these patients clinically and don't just look at the sodium value and interpret and then respond to every single value. So clinical monitoring is very, very crucial when you manage patients with hypernatremia. So the summary is electrolyte disasters are better prevented than being treated, because most of the times if we are able to plan therapeutic strategies better, we can definitely avoid catastrophe following overzealous correction or a rapid correction. So in hypernatremia, always fix the fluid first. Calculate the fluid, give the fluid first. Second thing is correct slowly. There is no hurry. We are not going to achieve anything by reducing sodium within 24 hours. Give it some time, do it slowly. Third, respect chronicity. Always presume that the hypernatremia would have been chronic, especially when you have an onset more than 48 hours. So that would have been time, adequate time for the brain to have accommodated and adjusted for whatever has happened, and therefore you have to go very slow. Monitoring closely, both clinically, biochemically, and more importantly is the urinary output. Many times we don't give much importance to urinary output. In this particular case, scenarios, you need to look at the urine output as well. So thank you very much, and I would end by saying that sodium reports are not just numbers, but more importantly, they just depict the water balance. Thank you very much.